My name is Sister Dr. Grace Nanyondo. I'm a gynecologist and obstetrician working with Ruwaga Hospital as the medical director. I'm glad to share with you knowledge about sickle cell in pregnancy today. Sickle cell disease is a condition where the normal hemoglobin, that part of blood that is supposed to be normal, comes out abnormal. It is an autosomal sickle cell disorder, autosomal disorder, whereby one of the amino acids, the valine, the glutamic acid is replaced by valine. And instead of having a normal red blood cell, which is round, now you have an oval red blood cell. Where when conditions of the body change, like extreme hot or heat, extreme dryness, extreme coldness, for them, they adapt to that condition by becoming extremely long, and they become long without going back, irreversibly long, such that when they are passing through thin blood vessels, they injure the blood vessels, they get trapped on the walls of the blood cells, they get sequestrated in the spleen. In the spleen is where the blood is cleaned. So it gets sequestrated. The cells are captured from there and they all congest there. So you end up having few circulating red blood cells, and their ability to carry oxygen is totally inhibited. They carry little oxygen, causing painful crises, the leg, the abdomen, the head, the chest, the stroke, the anemia, and name it. So these normal blood cells, for them, when they adapt to this condition, they are irreversible. They become long, but they are irreversible. When the condition change, then they become irreversible. Their oxygen carrying capacity is also not inhibited or affected at all. So this is the condition which I want to discuss. People who have it are usually born with it, and the burden is actually growing. And to make the matter worse, and because of improved medical care, many grow and reach reproductive age. And they also want to have children. So then the condition becomes complicated. That's where I want us to go and understand how do we care for these ones. However, the burden is significantly big, if I can take you back a little, that we have currently about 400,000 people affected with sickle cells. And 75% of these ones are living in sub-Saharan Africa. Tanzania is the leading country having people with sickle cells. Of course, since we are also part of the sub-Saharan Africa, Uganda is also having a good number of people living with sickle cells. So now, when they are planning to become pregnant, this is our starting point. They have grown, they have reached a reproductive age, and now they come to you, the gyne, the midwife, the doctor, the medical worker. What are you going to do? What do you need to know? This is what you need to know when they come close to you. You just know that when they come to you, you teach them right from when they are children, people who are taking care of children with sickle cells, that if they ever want to have children, they start with the preconception care. This care lasts for about 3 to 6 months. And this is where we prepare them to become pregnant. And what do we do during this time? We counsel them. We counsel them. The primary role is to counsel them. They need to know that sickle cell as a disease affects pregnancy, but also the pregnancy affects sickle cells. And how do these affect each other? Sickle cell affects pregnancy in that a woman who ever gets pregnant and has sickle cells, they have higher chances of complicated life, complicated pregnancy, higher chances of having gestational hypertension, preeclampsia, renal disease, retinal disease, pulmonary hypertension. They also have high chances of having frequent infections like chest infections, urinary tract infections, and meningococcal, that is meningitis, infection of the brain and the tube. So when you give them, that is how the disease, the pregnancy affects the disease. It complicates it in that way. So what do we do in this case? We screen them. We screen them for these conditions. We screen them for pulmonary hypertension by seeing a cardiologist. for an echo. An echo can tell you the state of the heart if the left heart and the right heart are functioning well. If they're not functioning well, then you are able to know that we already have a tendency to pulmonary hypertension. Then they go into it when they know, or they choose to go, or they choose to give it a second thought. And then you screen them for urinary tract infections and urine proteins. This one also screens also for gestational hypertension. And this one we pick the midstream urine and we do a culture but plus a urinalysis. We also screen them for infections of the blood. We screen them for renal diseases using also urine. Also screen them for the retinopathy because of these blood cells can affect anywhere. Remember, our body is made up of a lot of small blood vessels which carry blood, and in so doing, when they sickle, they injure, they break, and then they can cause a retinopathy. So you also have to involve an ophthalmologist to test them, to screen them for retinopathy. We have to do this as a multidisciplinary team. On board, there should be a hematologist, there should be a gynecologist and obstetrician, there should be a medical officer, there should be a group of people need to manage these guys because they have a lot of complications. And then we go back to how the disease complicates pregnancy. The disease also complicates pregnancy in another way because some of them have already said them and they are the same. Some of them are the same. The disease, the way the disease complicates the sickness, and the sickness complicates the pregnancy. Those are some of the complications, but they also affect the baby. The baby can fail to grow. They can die in the womb. They can get preterm labor. They can get missed abortions. They can also die. They can get anemias. All those ones are complications that are brought either by the pregnancy or the disease itself. So they need to know all this one is just about counseling. And they need to know about immunization because they are susceptible to encapsulated organisms. So they have to be immunized. In their immunization, we have in Haemophilus influenza B and meningococcal. This one, they get it once in their lifetime. And then they have the flu and the swine fever. This one they get every 5 years. And then they have to get every year an immunization for, for, for influenza. For influenza, they have to get it every year. So those are all immunizations. They have to get prophylaxis with penicillin. And those who are allergic to penicillin, we give them prophylaxis with erythromycin, the tablets, every day because they are susceptible to bacterial infections. So we have to put them on that prophylaxis. We have to stop some of the medications that they have been taking, like the ACE inhibitors, the propranolol, the hydroxyurea, which should be stopped at least 3 months before they conceive. As soon as they have become pregnant, we also have to screen them for iron overload, such that if they have an overload of iron, then we chelate them to make sure they have enough iron, which is not going to be toxic to the conceptus, rather the fetus inside. And then after which, now we go to conceiving and antenatal care. Conceiving and antenatal care is also put in stages or parts, or divided into 3 parts: the first trimester, the middle trimester, the second or the middle trimester, or the last or the third trimester. In the first trimester, when they have just conceived, remember we need to know the amount of iron they have to determine if they'll need iron. We have to start we have already planned for everything. So we start them on a prophylaxis. We have already immunized them. We have already screened them. But when they become pregnant, in the first trimester, the most common complication is dehydration from vomiting, lack of appetite. So that one is the number one cause of all the symptoms in the first trimester. So we have to aggressively manage the nausea, the dehydration from the vomiting and lack of eating, such that they live a normal life despite being pregnant. Otherwise, they will get all the complications of sickle cell even when during the first trimester. So after the first trimester, we do a scan at at 7 to 9 weeks. That one is just for viability. We do at 11 to 14 weeks. That one is for dating. We do for 20 weeks to assess extensive assessment of what? Of fetal anatomical survey if the fetus or the baby has formed well. But then every month we do a serial ultrasound scan to assess their growth because they are at risk of intrauterine growth restriction. And then penicillin I have mentioned, we have to assess them for for venous thrombosis and pulmonary embolism because they're at risk of it, and we give them prophylaxis for it. If the mother is sick and is being admitted, all admitted mothers with the sickle cells, we give thromboprophylaxis with low molecular weight heparin to prevent them from getting thromboembolic events. And then we have to do urinalysis and urine culture every month. Remember, we do their VIST frequently, at least 2 weeks every VIST if possible. Those who cannot, but at least we make a scan every month. And then we assess for blood transfusion if the HB is less than 6 or a decrease of 2 grams per deciliter from the original, the basic blood, the basic HB they have, we have to transfuse them. We have to assess their need of of self-transmission, cross-exchange transmission. And this one, we only do exchange transfusion in those ones who have acute chest syndrome and stroke. The rest, we really want to avoid it. We avoid them for, we screen, rather, we screen them for the blood sensitivity, the antigen antibodies, because some are sensitive already from the previous massive transfusions, and then we have to desensitize them. Mainly that is it about ANC, because remember we prepared them for conceiving, and then we do serial antenatal visits with as a multidisciplinary team, as I have said. And then time for delivery comes. When time for delivery comes, it's not a mandate, it's not compulsory that every mother with sickle cells has to deliver by cesarean section. They have a right, actually, and it's even safer for them to deliver via normal vaginal delivery. And what we do, if they are in labor, we have to give them epidural. We have to minimize pain. We have to minimize dehydration. We have to screen them for hypertension during that time as well. And then help them have a safe delivery, but prepare blood for them because most of the time they need transfusion after delivery. And if they have to deliver by Caesar, it should be an indication of cesarean section. Sickle cell shouldn't be an indication of cesarean section. And then if we have to deliver them, also we target elective delivery at 38 and 0 day. We shouldn't exceed that time if God has helped us to go through up to 38 weeks, because usually they get preterm labor and they deliver all we can deliver because of any other complication like intrauterine fetal growth restriction. So during cesarean section, the same applies. We give maximum pain management during cesarean and after cesarean throughout the healing process. But remember, we have to prevent the clot from forming. We have to prevent the clot by giving them low molecular weight heparin. So this one, if a mother has delivered safely, we give for 7 days. If a mother has delivered by cesarean section, we give for extended time of 6 weeks, because a clot can as well form even after 6 weeks. And then the baby takes the screening also to make sure they do not have sickle cells, or if they have, they are managed responsibly and accordingly. Then after delivery, we do prevent them from getting pregnancy or unplanned pregnancy. Natural family planning is the best. If they cannot manage natural family planning, progesterone only contraception is the first line, followed by estrogen. A combined because it predisposes them to getting a clot. And then we prepare them or we discharge them after preparium, like any other mother. They be looked after by another team as people with sickle cells, and if the child has sickle cells, be looked after by the pediatric team. And if then for us, we discharge them from our side. Thank you so much for listening to me.